My name is Nicole Arado, graduate student at The Ohio State University and chair-elect of the Student Advisory Council. I look forward to introducing the speakers of this interactive education program shortly, but want to review a few housekeeping details first. First, our program is being recorded, so anyone who speaks during it, for example, to ask a question, is agreeing to be recorded and is granting permission for the recording to be posted on our website. Second, we encourage you to put your Zoom on speaker view rather than gallery view. Third, many of us are working from home currently, myself included. If at any point my dog decides to bark, I apologize in advance. Today's program includes a structured discussion with our distinguished panel and then an open Q&A segment. You may use the chat function at any time throughout the event to share your questions or perspectives. Those will be saved for that Q&A segment at the end. Also, at the end, you may choose to unmute to ask your question aloud. So it's my pleasure to now introduce our panelists for today's program on coping with patient death and dying, tips for health psychologists. Our presenters include Dr. Christine Goteau, Clinical Assistant Professor and Senior Residency Development Program Director at the University of Arizona College of Medicine, Dr. Bernadette Melnick, Vice President for Health Promotion and Chief Wellness Officer at The Ohio State University, Dr. Michelle Pierce, Professor and Program Director of Integrative Health and Wellness at University of Maryland, Baltimore, and Dr. Carolyn Presley, Assistant Professor and Thoracic Geriatric Oncologist at The Ohio State University Comprehensive Cancer Center. If we were in person right now, I would ask everyone to give a round of applause. Maybe you can use the Zoom emojis or other features to show your support and excitement. And with that, I'll turn it over to our panelists. So let's start with just brief introductions. Would you please restate your name and then describe any specific experience that you have that is relevant to today's topic of discussion? We can go in the order that I introduced everyone. So why don't we start with Dr. Goteau?
Hi, everyone. It's so nice to be here. I am Christine Goteau. I am the Director of Behavioral Medicine in Family Medicine in a residency training program here in Phoenix, Arizona. We're affiliated with the University of Arizona College of Medicine and go by Banner University. So there's a lot of words to the department and program that I represent. I have worked for the past 12 years with family medicine residents who are in training towards their board certification and serve on a hospital-wide wellness committee that we instituted about 4 or 5 years ago prior to the pandemic. And I think the timing was pretty good in knowing that we needed to have a lot of components in place to help our healers who were in the earliest stages of their professional development come up with new habits or maybe finesse old habits, but to find a way to survive not just their residencies, but their entire careers, to preserve them, to take care of all of us as we get older. For 10 years, I also trained advanced practicum psychology students. I think I might have a student or two on this call, but we worked in tandem and trained health psychologists. At the same time, we trained family medicine physicians in our clinic, and our patients truly benefited from that. So thank you so much for the invite. I'm looking forward to this discussion.
Thank you. Dr. Melnick?
I'm so glad to join all of you today. I left sunny Arizona 9 years ago to come to Ohio State in a very pioneering position as the first chief wellness officer at a university in the country. So I spearhead population health and well-being for faculty, clinicians, staff, and students across our very big university and academic medical center. But I also have the privilege of serving as one of 60 leaders on the National Academy of Medicine's Action Collaborative on Clinician Well-Being and Resilience. Happy to see all of you today.
Thank you so much. Dr. Pierce?
Hi, everyone. I'm delighted to be here with you today. So I'm Michelle Pierce. I'm a professor at the University of Maryland, Baltimore in the graduate school. I'm also a clinical psychologist and a health and wellness coach. I'm a program director for our Integrative Health and Wellness Certificate Program. I also developed our Death and Dying Certificate Program. I no longer run that, but I had some experience with that. One of the courses I teach is self-care for professionals, and sort of later in the panel, I'm sure I'll get into why this is such an important topic for me, and I really feel like things like this are paying it forward. And then finally, I'm excited to announce that I published a book last September that feels very relevant to this discussion. It's called Night Bloomers, 12 Principles for Thriving in Adversity. So I'd be happy to share a little bit more about that later on too.
Great. And Dr. Presley, please.
Hi, I am Dr. Presley, Carolyn Presley. I'm an assistant professor at the University of the Ohio State University, and I'm a thoracic and geriatric oncologist. So I'm on the research track. So I spend a lot of my time doing research among older adults who are experiencing advanced illness. So the majority of my patients do ultimately die. And so I design supportive care interventions to optimize their functioning and quality of life during this finite period of time that they're under our care. And so I work at the James Cancer Hospital, which is the large building behind me in my Zoom background. And I'm thrilled to be here today. So thank you.
Great. Thank you, everybody. Our first official question coming up. Patient death and dying is an inevitable hardship in our field. The frequency of these events has increased due to the COVID-19 pandemic. What are some techniques you have used in order to cope with these challenges or help others cope over just the past year?
So I'll go first. There is a technique, a short one, that we use at our medical center, specifically in our critical care units, but it's used all throughout the nation and globe. It's actually called the pause. So it's taking just 1 minute after a patient dies for the team who cared for that patient to come together for just 1 moment to honor that patient and also to really appreciate the work of the team. Interestingly enough, because I'm a researcher too, and I'm also super into evidence-based practice. In fact, I have a philosophy: in God we trust, but everybody else better bring data to the table. The pause, even though it's used all throughout the world, I mean, people have caught on to this like crazy. It doesn't have a ton of research behind it. There's just a couple small studies, but if you talk to clinicians who use it, they say it's very empowering and it really helps them to cope with that death.
That's great. Thank you for sharing. I'm actually interested in how we could potentially do that in the outpatient setting, because usually our notifications now are actually through email, right, from the hospice agency that the patient has passed. So, or from a family member phone call or something like that. So I think that would be really interesting actually to try and adapt to the outpatient setting where the patient isn't necessarily there, physically there, right? But we hear about it in a pretty impersonal way, actually. So that would, I think, be something really interesting. A couple things that we do that some of them have been researched, some have not, some are part of ongoing active research is one of the first things I did at Ohio State was create an embedded palliative care clinic in my thoracic clinic. And so I actually brought a palliative care physician into our team. And so it's pretty seamlessly integrated where the patient either sees the palliative care physician and then me, or me and then the palliative care physician, or a lot of times we're actually in the room together, particularly if it's a challenging end-of-life conversation for a patient who's highly symptomatic and resistant to stopping their cancer treatment, right? Because at least for patients with cancer, and I know this is not a cancer-specific talk, but they have to make the terrible choice in the United States unless they're receiving care through the VA, actually. So they have to choose between their cancer treatment and hospice. And so that's a really sticky point for a lot of patients. So incorporating palliative care, not only, I mean, of course, this is a huge luxury for us, right? But the principles can be incorporated into a lot of different care settings. The other thing that it's not really like the pause, but we actually have quilts that are handmade. And when a patient goes to hospice, we actually give them a quilt. And most of us actually do like hug the patient and their caregiver and say goodbye, right? So I do think sort of saying goodbye might be helpful or therapeutic for the care team. Again, another great research study that's waiting to happen by some grad student out there. But again, we don't have data like for the pause, but I think it is a tangible instrument to do the pause in terms of reflecting on saying goodbye and how much we're going to miss the person and things like that. So my care team's actually pretty good about doing that. And of course, in the past year, it's been really challenging because so much of it has been distanced in terms of families not being allowed in the ICU or not allowed in the hospital. And so we're doing a lot more via telehealth and virtual health, but I still call the family after the patient has died. And I honestly think that's probably more therapeutic for me, but it also might be really therapeutic for them. But I do call the family after the patient has died and I send them a card. And again, these are all little things, but I think it is getting at what Dr. Melnick is saying, is that it must be creating some sort of space to actually process that someone that you've seen very regularly for a certain amount of time has, died.
Nicole, if you'd like, I could.
Oh, go ahead.
Sorry, Christine.
No, that's okay. You take it.
I was just going to say, I could speak to an outpatient clinic. So as a psychologist, because I'm not in the position, I'm not working with people who are dying or near death, but I have dealt with a lot of grief and a lot of loss in the last year. So I've been recommending that my clients do all the things that I've had to do myself. So things like I started back up my regular meditation practice, and that happens every day now, even if it's just for 5 or 10 minutes. Journaling, walks in nature, connecting with people, even if it's just, like this over Zoom, like that was really important every day. Another thing I noticed that's been helpful for me and my clients is like permission to be less productive. And that was a tough one. Like there was some expectation that, well, you're at home and you don't have the commute and maybe you have fewer things going on, so you should be available more often, right? Like you should be more productive. And I just found, as with my clients, we're less productive, and it makes sense based on what we know about brain chemistry. And so a lot of it was like, permission to not be okay, permission to take care of yourself, permission to take a mental health day, permission to not be as productive. And those sort of strategies have been really helpful.
We hold space in our residency for support groups. Normally, this would follow like a quarterly ambulatory cycle, but when Arizona hit our surge relatively early in the pandemic, I think July, we were leading the world, and we had multimodalities where we went up and down, but we were pretty early and moved very quickly with support from our institution to have weekly support debrief types of groups. And what I found as we progressed is, although we save space to process things like when there are a lot of pauses, or when there are so many calls to the family, or when just the logistics of the pandemic meant that one couldn't, like we get really hot in the summer, so you can't go outside and take a nature walk, or you weren't able to see people, or you did see people who were maybe violating what you thought was the right thing to do, sitting out having lunch or whatever together, when you then went to the hospital and worked in the ICU for shift after shift. So we save space to not talk about the pandemic, because so much of our healthcare providers' entire brain was taken up with dealing with it and not being afforded the luxury of pretending it wasn't happening through their work. So although the idea was to have support groups to process and air just the very mixed emotions and the very real feeling of hopelessness and helplessness and being overwhelmed and really, frankly, very angry as the pandemic has raged on, we spend some time doing that, but we also spend time not talking about that. And that's a real respite to continue to feel that support and those relationships amongst fellow trainees and fellow physicians and faculty and staff who are all experiencing this at the same time, but probably even the people most intimately close to them at home don't really understand the unique pressures that this last year has brought and continues to bring.
Absolutely. Thank you, everyone, for the many different perspectives that we're able to provide here. We've already kind of touched on some aspects of the following question, but it says that in terms of stress, we may bury ourselves in our work and neglect necessary self-care. So the feeling of being burned out seems to sneak up on us. So 2 questions related to that. One is, how can we identify early signs of burnout and try to prevent its full onset? And for those of us who recognize that we're already burned out, how can we reestablish a balance and move forward?
I'd like to build on what Michelle talked about, this self-care piece. Clinicians do a great job of caring for everybody else, but they often don't prioritize their own self-care. And that's why we're seeing rates of burnout right now between 50 and 70%. I've got a big national study of critical care nurses coming out on May 1. The level of depression is impacting about 40%. The level of clinical anxiety and burnouts well over 50%. So if we don't grow up our clinicians while they're in our programs to take better self-care, they're not going to have those skills to manage their stress and burnout when they get to the real world. But I also want to share, you can have the strongest wellness cultures that you can build, because that's really critical. Cultures that make self-care, healthy behaviors the norm is really important for sustainability. But if there are system issues that need fixed, we can have all the wellness programming evidence-based because we know what works. We just got to translate it in the practice. But if you've got a system where people are short-staffed, they're working long hours. We need to stop 12-hour shifts for clinicians. My research shows 12-hour shifts are associated with high rates of mental and physical health problems. But our hospitals continue to do that. Again, we can't wait 30 more years to stop this. To know but not to do is lethal, is what I call it. So I could talk for hours on this topic, but I'm going to stop there. But leaders in organizations must walk the talk. Because if they're just preaching, you got to engage in wellness and self-care, and they're not doing it themselves, their clinicians are not going to do it either.
Yeah, Bernadette, that's such a good point. It goes sort of towards my own personal story. I think it's easy for us as clinicians to have this disconnect between intellectually what we know and what we're learning, and emotionally what we feel is true for ourselves. So to make it personal, when I went through grad school, I learned all this about wellness and integrative health and stress and taking care of yourself. And I taught all my patients how to do all that. And I burnt myself right out. I ended up with a stress-related illness, and I was out for a year, basically bedridden for a year with a stress-related illness. And then I finally got it, right? Like I finally got that, yes, stress impacts all of us, including providers who are teaching clients about stress. And that's when I realized, like, I have to figure this out for myself. This is not just something I teach. This has to be something that I practice. And so the way I teach it now is about filling my cup, that I am the instrument of healing, whether you're a psychologist, a therapist, doctor, oncologist, like you are the instrument of healing. And if you are not taking care of yourself as the instrument, you have nothing to give. So that's really where my messages come, is that we must look at self-care as healthcare, not as an extra, but as healthcare itself.
I think we're starting, the paradigm is shifting, and we are starting to make those moves to appreciate how important that time away from work is. And again, it's hard to wait when it's really systemic change that we need, and destigmatization, which we're on a journey, but we're not at the end point yet. But I think one component that sometimes gets missed, and maybe it's more salient for me because I work with residents who really have no control over their schedules, and they are really, though they may rail against and completely agree with you, Dr. Melnick, like there's very little they can do in these years in which there are residents really face that. And if it's a necessary but not sufficient condition to know how to care for yourself when you're not at work, to leave that there, clock out, yoga, outdoors, gratitude, you name it. But if we miss the component that we help guide our healers to connect in their work, not just away from their work, not when they leave that behind, but that their self-care and wellness takes place within the context of the relationships that they get to have with their patients, wherein they can feel that stress, maybe recognize it earlier, but then take that moment to take a breath and ask a question and listen to the response from that human being from a place of curiosity and thereby compassion, that if they can connect to the meaning in their work while they're doing their work, it goes a long mile kind of meaning that makes it worth it to have been so ambitious in life to say, I want to do these huge, big things that are going to cost me 10 years in grad school, like everyone on this call, or to be a physician and work these 12 hours and 80-hour, duty hours weeks. Why am I doing this? And I think that's the crux of the question in ultimately facing, burnout is a really derogatory term now, and we're kind of turning away from it because it sort of blames the person who's experiencing that moral injury when it's probably systemic. I'm agreeing with the other panelists. But the simplest things that someone can still do before the systemic change takes place is to truly take a step back and try to connect with the people who populate the work that we're doing and really re-engage with the relationships that we're privileged to have in the work that we get to do.
So just to build on, thank you everyone for these amazing comments. This is incredible to hear everyone's take on this issue and what we should do. I agree that work hours continue to be a constant issue, whether it's residents, nurses, med students, trainees, trainees at all levels, grad students. And that's definitely needs to continue to be addressed on a systemic level. But in terms of symptoms, I think I do call it burnout still. And so I'm actually interested to hear you say that it does place the blame on the person, like I burn myself out. I've never heard that. So thank you so much. I really appreciate that. I also think there's less stigma saying, I'm pretty burnt out, rather than saying, I have depression or anxiety, right? It does take away, I think, a little bit of that stigma, because I don't feel like I have depression or anxiety, but I'm definitely burned out, right? So I do think, but the words matter, right? And so I'd love to know different words that people use to describe it now, because I think particularly, and I'll just speak for physicians, saying I have anxiety or depression is still really there's still a huge stigma with that. That being said, I myself and my other colleagues in residency did experience severe burnout. And I do think that did propel me on my path to become actually tenure track faculty, because doing research was not the balance, because I actually don't like that word either, but was part of my career that I needed to keep going, right? I couldn't just be a clinician working 100+ hour weeks, being on call every other night, right? That was my residency experience. So I knew that research was a place where I could rejuvenate and be creative and like fill that cup, right? But I do think the signs and symptoms can be different, and really irritability, I think, being a primary one for burnout, or whatever you want to call it. And I'd love, if there's a new name, please let me know and I'll use it. But I think irritability, frustration, and anger are what I think of more as those key triggers, Nicole, that sort of you were looking for. At least in my experience, that's what it was, or like the blow-ups, right? And I think at least for physicians, that's what I tend to see more, or just withdrawing completely, right? Just totally shutting down. And so I did have to develop my burnout prevention plan, but most of it I have to pay for, right? And so I do think on an organizational level, like Headspace made free subscriptions for healthcare workers during the pandemic. Our employee assistance program is free for the first 5 sessions, but then after that, you have to pay for it, right? There's no and I don't think any other institution and maybe they do, but I'd like to see a system where you have free monthly counseling, therapy, or psychology, whatever you want to call it. So I know that I have, because I deal with so much death and dying and high stakes, right, clinical care, that I have to see a psychologist once a month that I pay for. And I also have an academic coach that I was able to get that reimbursed, but not my counseling, right? And I also have medication that I have to pay for, right? But these are the things that I know I need. And I just signed up for an exercise app that I pay for, right? because I don't want to go to the gym anymore. So I think this investment in health and wellness, and I'd love to see these supportive groups that Dr. Goteau is talking about in terms of like in residency, we actually had that, but I have not had that at any other level of my professional training. And so I've actually created that for myself at Ohio State among other women clinician investigators. But it was our initiative, you know, it was us, but that peer support is so important. And most of them also have small children, which I also have. So finding that peer support group, informal, is usually, I think, the way that people are going now. But these are some of the tools that I've found, but they're mostly funded by me. And I have a salary that I can afford those things. But it would be great if the system would also provide, would encourage those over time, not just for the crisis moments. They will pay for those crisis moments, but not the long-term investment.
Carolyn, we need to get together after, because we're both from Ohio State, but we never met. But I want to build on a couple of things, because in benchmarking with so many other universities, we offer so much more in terms of wellness than a lot of others do. But I want to build on a couple of things you said. I'm a psychiatric mental health nurse practitioner. And when you said this irritability and anger, oh my gosh, I think that masks not only burnout, but depression and anxiety. I've had so many clients that present with irritability and anger. The red flag, though, always is, are those symptoms starting to interfere with concentration, judgment, and functioning? That's where we kind of cross that line. And what I want to emphasize is sometimes all we need to say to our colleagues when we see them like this, are you okay? I mean, just that simple question does wonders. And the other thing is, we do have a lot of evidence-based, brief interventions that can help in the moment. For instance, look at my Zoom backdrop that says, have you taken your vitamin G today for gratitude? So we have units actually that have created gratitude boards. So when staff come in at the beginning of their shifts, they write down one or two things they're grateful for. I can't tell you the success we have had with that. 5 deep abdominal deep breaths using the 5-7-8 method. You can do that during your busy days, but that helps. Self-affirmation statement. So we gotta help our clinicians build this resiliency, these protective factors, because we know they do work, but we gotta fix the system issues too, for sure.
Thank you so much. I think that this will be the last question from me, and then we'll open it up to the audience to see what is on their mind. So this is kind of a broad question. Many of us in the audience are graduate students and trainees in health psychology and related fields. So looking back at your training and at your early career phase, what is one thing you wish you'd known back then? This could be related to coping, burnout, or more broadly about quality of life. We want your words of wisdom.
I was raised Catholic, so I've got a big conscience. You know, I grew up with a lot of guilt, and I wish, seriously, I still work at this. I'm so passionate about everything that I do. And I often say yes to so many things. And I will do whatever to follow through on what I said I would do. But my own personal well being suffers for that. I have a couple of good friends that said they're going to make me a button that says my lips say yes, but I really mean no. And I do think we are overachievers. We want to do a great job. We tend to overcommit. And I work at this all the time. What are my biggest priorities? What are my biggest passions? Because if we stay aligned with our dreams and our passions, we'll never feel like we work a day. So those are just some tips that people don't talk about usually.
I can share. So I already shared how I wish I had known that stress was a big deal, and it was a big deal for me as a provider as well. So I'll share one other, and that is the power of perspective. And I mean, as we all know, we don't have much control over what happens in our lives. I mean, take the last year, for example, so little of it was under our control, but our perspective is under our control. And so just to offer all of you, in psychology, you know, we call it post-traumatic growth. What I wrote about, I called it blooming in the dark. I think it's a nice metaphor to remember. So if you think about, there are some flowers that actually require the dark to bloom. And that, I mean, just that idea that they don't just bloom in the dark, they require the dark to bloom. And I think there are some people that also require the dark times in life to really grow and reach their full potential. And I call us night bloomers. And so that's something that I wish I had known much earlier on in life, that there was this another perspective on adversity, that it doesn't just have to destroy us. We don't just have to have lost a year of our lives. It was miserable. I mean, the last year was one of the worst years of my life too. And there is a lot of research that supports that for a lot of people, that when you go through really difficult times, there's some really positive outcomes that are possible that are not possible without going through that adversity. And I think it's really important that we hold on to that perspective and we hold on to that hope, and that we offer that to the people that we're working with that are suffering, that there is hope, that there is this other possible outcome for you.
Thank you very much. I can open it up to our audience unless there are other things on anyone's mind.
The only thing I would add, Nicole, is I want everyone on this call to know you're going to get through it. It really sums up everything you just heard from the wisdom of the co-panelists. But it seems silly, but there are times where you think it's not going to ever end, and it does. And you will make mistakes, but like the night blooming, I love that. It's absolutely beautiful. It's exquisite as a metaphor, but you will grow from that. And it isn't something to be afraid of. Just keep your people close, keep a group of people that you've developed relationships with already, probably at a moment's dial. You may not be able to come up with a really fancy consultation group right in the moment when you need it, or maybe you'll already be established in one and you'll be ahead of me in every way that I haven't. But just having a friend or two you can redact and talk about things with can go a long mile for your own self-compassion and perspective. And make mistakes, grow from them, and you're not going to be perfect. And that is great, because then you'll be incredibly relatable, and you'll be able to sit on a panel like this and share all of the war wounds that it took to get just in that brief period of time for being a trainee to being someone, God forbid, seasoned. But it's going to be okay, and you'll get through, and you'll be glad you did it, even if you don't believe me right now. It's worth it.
And I guess the last thing I would say is that there are just a lot of tools out there, and there are a lot of resources at your institution, and people want you to succeed. I would say that's the bottom line, is that people want you to succeed and do well, even if it feels like what you're doing at the time feels impossible. There are so many people that you wouldn't really realize are rooting for you, so that if you do need help, to reach out. And it could be to anyone. It could be a colleague, it could be a family member, or it could just be someone at your institution. But there are a lot of resources out there in a lot of different ways. And what works for one person might not be the right recipe for you. And to not feel like, oh, I'm out of balance, or I guess I'm not burned out, but I am suffering from something, from whatever the pressures are. And that sometimes the ups and downs, and that's okay, and it's normal, and it's nothing to really be ashamed of.
Thank you again. Audience members, this is your time to shine. You can unmute, show your face, ask what's on your mind, or you can type it into the chat and I can read the question. If we're still thinking of questions, I can always ask more, because it's not every day that we have a panel of these amazing people on call to ask these questions.
I can ask a question.
Okay.
Hi, everyone. Hi, Dr. Goteau. Nice to see you. Thank you so much for all your recommendations and advice. This has been fantastic to hear. I think one thing that struck out to me is this validation of how institutions really, sometimes make it really difficult to engage in these practices, right? Because we're asking so much of providers and trainees. So I'm wondering if any of you are willing to share your recommendations or experiences. How do you maybe engage with supervisors or people in higher powers in those institutions to have these conversations and maybe even advocate for those systemic changes? I'd love to hear if you have examples of how you've done that in your spaces.
That's a great question, Roberta. Thank you for asking that. I think institutions that really are invested in well-being for their people, they will invest in a leader like no matter what you call that person, whether it's a CWO, a director of the health promotion, but you need somebody at that level that interfaces regularly with top leadership. For example, tomorrow, I'm actually presenting data that we've recently collected to our medical center's top leadership. And we will be discussing, where we're doing great and where we need to improve. So I think a top leader who can interface regularly and always negotiate with data. So this is a really important thing, because the C-suite in many organizations, they think wellness is a nicety. It's a warm and fuzzy thing. Instead of, this is foundational to the success, to healthcare quality, safety, decreasing turnover and costs. But there's still a lot of C-suite who really don't get that. So you've got to anytime you're negotiating, you got to bring best evidence to the table, and you'll be much more successful than not.
I'll add to that, Bernadette. Those are good ideas. And Roberto, let's imagine you're in a program or a practicum setting and there is no one that's sort of advocating. They haven't invested in that. And I had a graduate school like that. In that situation, I would recommend look around you and find someone who's in a leadership or a faculty role who's living more of the balanced life that you want to emulate. So I remember in grad school, many of my advisors, they'd send me emails at 2 a.m. And I learned pretty quickly that I was supposed to be up at 2 a.m. and working. And that kind of culture led to my own burnout. So I determined, once I got better, that I was going to be one of those faculty role models that students and others could look to. And she got there at 8:39 and she left at 5 or 5:30 every day, no matter how much was on her plate. And so people could look around and say, that is one faculty member who's doing her best to live out a balanced life. She's not ready to be back at 10 a.m. or 2 a.m. So I would just advise, look around your program and see if there is anyone that's more balanced, and they might be able to play more of that mentor role for you.
I can't believe I'm going to say this, because in my career, I never thought that any committee could actually accomplish a darn thing until I joined and helped, craft the wellness committee that we have been shockingly maybe successful at getting through to the C-suite. Granted, timeliness is important, but I would encourage all of you to think about this yesterday, because now's the time. We're seeing the physician death by suicide through the roof. That was prior to the pandemic, by the way. Some of the things we talked about on the panel, the levels of depression and anxiety, and where vicarious trauma is going to go post-COVID-19 when we finally get to the recovery phase, which is going to be purely mental health, I anticipate. But the numbers are there that the people in healthcare are suffering. And as health psychologists, you will be called upon to answer for what we're supposed to do with that. We formed a committee. We incorporated residents, program directors, C-suite leadership. We have a Cultivating Happiness in Medicine committee, because we're a huge bureaucracy. Oh gosh, it's being recorded, but banner's huge. And we started, because I'm a health psychologist, I said, we can sit here and brainstorm all day what our stakeholders want, but we need to ask them. So we did resident-driven needs assessments, and exactly what we thought. Like, leaders thought, oh, they need more computer stations. They didn't need computer stations. They wanted healthy food. They wanted a place to come together. They wanted sacred space that wasn't the basement or the back of a mop closet, where they could interact intra-specialty. And somehow, I don't know how, maybe we were lucky, maybe it was a miracle, but because we were persistent and it took years, we got the top floor of the hospital that was the VIP suite converted with yoga and Pilates and a foosball table. My gosh, I, in my career, have seen a order go through corporate for a foosball table for resident wellness. We have, speaking to Dr. Presley, we have now, I'm in the process of on a committee to hire a captive psychologist just for residents, so they don't have to pay. We have gym equipment, so they don't have to pay. We borrowed old, which was fantastic because it was cardiology cast off like equipment, but got that and secured that for our healthcare providers. So I offer you this hope that people are waking up, though the old mold was, we'll just burn them out and expire them. We're finding that we may not be able to replace the number of physicians and psychologists and therapists and MAs and staff that are vacating the profession because they're coming to grips with the fact that they could do something maybe a little better with their lives than suffer through a pandemic. So now is the time to come together with a few other like-minded individuals, find someone like Michelle's talking about who you relate to, who you feel like could be a partner with you, and ask. And if you get no, keep asking, persist, because I'm here to tell you, it's possible. I never thought it was possible. I thought I was taking out the trash with my committee work, but it's really possible. And it's the right time to ask for wellness initiatives. There aren't enough of us, and the population does need you.
Thank you so much. I feel inspired to go ask all the questions that I've been waiting to ask, and I have had no, if these things are so important to keep in mind. One final question from the chat. My dog says hello. Dr. Claire Conley says, could you please speak to some of the differences between coping with losing a patient to illness versus losing a patient to suicide?
Yeah, that's a really tough one. Honestly, I think that obviously it's both circumstances are really hard. And I think as a physician, you can blame yourself in either situation, right? So, but I do think they are processed differently. I still call the family and check in with them. I still send a card. I don't think I treat it differently in terms of how I respond to the family, but I think, do a little bit more process around, is there anything I could have done differently in terms of trying to get that patient the mental health care? Because often, and this is something that I also advocate for, is that there isn't enough mental health care, right, in all areas of our healthcare system, but particularly within, so I treat patients with lung cancer, which have a very, very high rate of anxiety and depression. And I have had patients commit suicide. And so I do think that's in part why so much of my research is with not screening and treating anxiety and depression at the moment of diagnosis. And actually, Nicole and I work on this very closely together, because a lot of times it is not commonly screened for and treated, because there's so much going on when you're treating a severe illness such as cancer, that they have to go together. And I think there has been sort of a paradigm shift within cancer care, that we're recognizing it now, that yes, it is important, but we're really working on operationalizing it. So I do think there's an added element of, was there a missed opportunity? And if so, where can we intervene, right? And a lot of times you can offer as much help, but the person has to be open to receiving that help. And sort of, despite sometimes your best efforts, you can't prevent it, but you have to make sure that some of those mechanisms are in place. But I do think it is a different process, but again, one that needs to be processed, right? Because it's a loss. And again, it's nothing to be ashamed of, but it is a different process, but one that's just as important or even more important, because you have to make sure that you're changing your processes if you think they need to be changed, or bolster them in different ways to provide the care that might be needed. I don't know what others think, but that's my take on it.
I think suicide is just so tough, really, for clinicians. And it gets back to, oh my gosh, could I have done something differently than I did? So that survivor guilt is so real for so many, not only in the family, but the clinicians. Now, I do want to point out something that I think is important for clinicians. There was a study that was just done by one of my colleagues that showed nurses kill themselves at higher rates than the general population. But what she found that wasn't found recently, there's usually a work-related issue close to that suicide, whether it's a medical error or a problem in conflict with another team member. So we just, again, as we talk about self-care, Carolyn, you talked about the screening piece. I applaud you because I do so many workshops for physicians, nurse practitioners on how to better screen, intervene early for these mental health issues. Because if we don't deal with the mental health issues, which are so comorbid in so many people with physical health issues, you're not usually going to see big improvements in the physical unless you deal with that mental health piece. And now we have a mental health pandemic inside of a COVID-19 pandemic. So this piece is so, so key.
Certainly lots to thinking about. I just want to keep an eye on our time and respect everyone's time. So with that, on behalf of the Student Advisory Council and all of the Society for Health Psychology, please everyone join me in giving a huge thank you to our panelists for taking the time to share their experience and their wisdom with us. Thank you to all the members of the audience for your attendance and for your engagement. Just a quick reminder to renew your SFHP membership for 2021 if you have yet to do so. This will enable you to participate in the teleconferences, webinars, listservs, awards, all the benefits all year long. And remember, it's not necessary to be an APA member in order to join Society for Health Psychology. As stated earlier, the recording of this program will be posted to the SFHP website and the private YouTube channel that we have. If you have any follow-up questions or comments, feel free to email me. I'll put my email in the chat. We look forward to seeing you at future events, and I hope you have a great rest of your day.